Hi friends, let's study today's spread of oral infection from oral pathology. Okay. First disease is osteomyelitis. Inflammation of bone and its marrow is called as osteomyelitis. It is divided into suppurative, which is pus forming, and non-suppurative, which is non-pus forming, which is also called as sclerosing osteomyelitis. Okay. Suppurative is further divided into acute and chronic. Non-suppurative is further divided into focal, diffuse, and garious osteomyelitis. All three are chronic osteomyelitis. Now, predisposing factors which are the factors that may be responsible for this osteomyelitis disease. Okay, so fracture due to trauma and road traffic accident. Okay, or road traffic. Okay, gunshot wound, radiation damage, Paget's disease, and osteoporosis. Okay, because in osteomyelitis is common because in osteoporosis defect of osteoclast is present, and which increases the activity of osteoclast, which decreases the blood supply of that part of the bone. So osteomyelitis can occur there. Systemic conditions: malnutrition, acute leukemia, uncontrolled diabetes mellitus, sickle cell anemia, and chronic alcoholism is the systemic conditions which cause increased osteomyelitis. Okay, then um, let's study in detail about acute suppurative osteomyelitis. Increased severity takes place in decreased time. Acute means, you all know, I guess, that increased severity and in less time. Okay, diffuse inflammation of marrow, less time, diffuse inflammation of marrow, it is diffuse. And the most common predisposing factors are is pulp. When get infected, it get necrosed, and then periapical area may these three can occur: periapical granuloma, cyst, and abscess, which further goes to the bone and cause osteomyelitis. Okay, then now etio etiogenesis. Okay, cause: many microbes are also responsible for this. Polymicrobial infection are staphylococcus aureus, staphylococcus albus. Okay, then streptococcus, bacteroids, porphyromonas, and prevotella. Then pathogenesis: infection, acute inflammation of marrow. Inflammation exudates spread through marrow spaces. Infection can occur, then acute inflammation of the marrow gets inflamed, and inflammatory exudate. Then exudate secretes from the inflammatory side and spreads through the marrow spaces and spread through the marrow spaces. Okay, then further compression of blood vessels results in thrombosis and necrosis of bone, which is called a sequestrum, which is a dead bone. Okay, extends through cortical bone to involve the periosteum. Extends through cortical bone with cortical bone to involve the extends through cortical bone to involve the periosteum, causing lifting of a periosteum. Okay, then when it occurs, sequestrum form, and then decrease blood vessels and thrombosis and necrosis of bone, sequestrum form, and it extends through the cortical bone to involve, and then it extends. What extends? Sequestrum or necrosis or thrombosis extend to the cortical bone to involve the periosteum, causing lifting of periosteum, which cause the lifting of periosteum. Yes, we have seen the diagram of osteomyelitis. If not, I can show you here. It causes the one second lifting of periosteum. Okay, it is not given here, but of chronic it is given here. It causes, I have seen one. Okay, Just remember, it will cause the lifting of periosteum. Okay, this is called as periostitis. Lifting of periosteum is called as periostitis osteomyelitis. Okay, then clinical features are jaw swelling, okay, which is lifting of carious tooth and PDL tissue. Carious tooth also lift, and PDL tissue surrounding it will also lift. Fever can occur, increased temperature, pain, paresthesia of lip. Okay, it is most common in mandible than maxilla. Maxilla is more porous. Okay, because maxilla is more porous, so it will be more common in mandible, because mandible is less porous, so sclerosis will occur there more, and then blood vessels decrease, blood supply decrease there more. Okay, then draining sinus is also seen. Which is plus pus discharge can also be seen in this suppurative acute osteomyelitis. Okay, it will also be included in the clinical feature. Okay, but it will not include in the non-suppurative osteomyelitis. It is a common sense, okay, radiographic features take 1 to 2 weeks for a significant radiological features. Yes, it is the most important point, that osteomyelitis will take 1 to 2 weeks for significant radiological feature. Bony trabeculae, uh, Bony trabeculae appears fuzzy, not clear. Moth-eaten appearance. It is suppurative, so it will not be clear. So in radiograph, so bony trabeculae appears fuzzy, not clear, and which may appear as moth-eaten appearance. Radiographic features are not significant, but here in acute, but significant in chronic osteomyelitis. Okay, then histological features. Biopsy we will take. First we will curettage, and then we will do biopsy. Then inflammatory exudate we will take, and which shows increased nuclear lymphocytes, neutro lymphocytes, and then less lymphocytes and plasma cells. Less lymphocytes and plasma cells are also seen. Okay, but the PMNLs are more. Okay, then treatment. Debridement of necrosis of bone. Okay, necrosed bone, debridement. Drainage of pus. How to treat it? First we will debridement. We will do the debridement of necrosed bone, and then drainage of pus, and then we will give strong antibiotics, and then reactivate bone formation. Reactive bone formation starts. Healing in volcrum, live bone will occur. Then reactive bone formation starts. Okay, reactive bone formation starts. Okay, after giving strong antibiotics. Okay, and after draining pus. Now chronic suppurative osteomyelitis, less severe, long standing, de novo. De novo means it is chronic suppurative osteomyelitis is less severe, it is long standing, and de novo. De novo means on its own, it will occur on its own. Okay, so acute can convert into chronic, and chronic can also convert if aggravated or exacerbation can occur, and it will convert into acute. Okay, so clinical features: fever, but it is low grade. Swelling is also present. Mostly patients asymptomatic and not severe. Okay. Radiographic feature is mosaic pattern of bony trabeculae. Mosaic pattern of bony trabeculae. Okay. This is, we have to remember that in the acute suppurative osteomyelitis, we see um, what moth-eaten appearance, and here we see mosaic pattern of bony tuberculi irregularly arranged. Okay. Then histological features: lymphocytes and plasma cells are increased in number than acute one. Uh, Lymphocytes and plasma cells are increased in number than in the acute one. There plasma cells and lymphocytes are less and more in number are PMNLs, but here lymphocytes and plasma cells will also increase. Okay, and treatment is debridement and give antibiotics. So now suppurative type, non-suppurative type. Suppurative type, we have completed acute and chronic. Now chronic focal sclerosing osteomyelitis, it is also called as condensing osteitis. Okay, um, it will look like this, and around root it is sclerosing condensing osteitis, spherical spheric spheral, what it is written, I have spheral type of osteomyelitis. Okay, let's leave that. Spiral means I guess spherical type of osteomyelitis, which surround around the root, tip of the root, is spherical. Okay, because here bone is responding by proliferation rather than destruction. Because here bone is responding by proliferation, because here bone जो है वो is responding by proliferation rather than destruction. Okay. So, good host response. In this, host response is good. Vascularity is also good. First molar areas. Okay. Young adults may it will occur in this white pulp is present. White pulp, first molars, young adults. Okay. Good vascularity. Infection here not as a irritant, rather stimulus sclerosis, not irritant but stimulus sclerosis. Okay, seen periapical radiopaque mass, seen as periapical radiopaque mass, but outline of tooth is visible. Differential diagnosis from cementoblastoma. Outline is not visible in cementoblastoma, but here outline of teeth root is visible. This is chronic. In this in this diagram, this is diffuse type sclerosing, but I guess focal sclerosing type is also like this only. Bone scar. Yes, this is the chronic focal sclerosing osteomyelitis. This one looks like cementoblastoma, but in cementoblastoma the apex of the root is not visible. Okay, here it is visible. Okay, let's continue then. Okay, then treatment, we will do RCT or extraction of the teeth. Sometimes little bit of bone tissue is left behind, so it will form bone scar like this. This one is the little bit, after extraction little bit of bone tissue is left and it will form bone scar. Okay, it will form bone scar. Residual condensing osteomyelitis, bone scar, residual condensing osteitis is this. Okay, then histopathology of bone scar, we see bony trabeculae, prominent resting end line and reversal lines. Of bone scar, we see bone trabeculae, prominent resting end line and reversal lines. Here histopathology is of bone scar In bone scar, in a slide we see bony trabeculae, prominent resting and reversal lines. In between these trabeculae, there is very minimum interstitial tissue fibrosed, increased collagen bundles are present. Okay, between these trabeculae, okay, there is very minimum interstitial tissue between these trabeculae is very minimum, and which is also fibrosed, so increase collagen bundles. Okay, now chronic diffuse sclerosing osteomyelitis involve large area showing sclerosis. Okay, now chronic diffuse osteomyelitis, sclerosing osteomyelitis involve large area, which involve large area because it's not focus, it's focal, it's diffuse, so it will involve large area showing sclerosis. It is least common due to the infection coming from pulp, but more common from PDL pathology because it is of larger area, so it will involve most common ETO is PDL pathology. Then if we have to choose, then we will choose from pulp, coming from pulp, and in focal we will choose first coming from pulp. Okay, then clinical feature, it is asymptomatic, found under routine investigation. Clinical feature, radiographic features are radio opaque mass. It is radio opaque mass is not regularly organized, so which is not regularly organized, so give cotton wool appearance. So in chronic diffuse sclerosing osteomyelitis and in Paget's disease also, sometimes in fibrous dysplasia cotton wool appearance is seen. Okay, then bony trabeculae, histological features are bony trabeculae which are empty, which have empty lacunae, no osteoclast, show prominent resting and reversal lines. Treatment is we will do if remove source of infection. Okay, remove source of infection. If PDL pathology is present, we will remove that, but we will treat the patient of this osteomyelitis only when if symptomatic. If asymptomatic, we will not treat and we will leave it as it is. Okay, now chronic osteomyelitis with proliferative periostitis. Okay, which is a Gary's chronic osteomyelitis, or Gary's osteomyelitis, Gary's chronic non-suppurative sclerosing osteomyelitis, or periostitis ossificans, or chronic osteomyelitis with proliferative periostitis. Periostitis or ostitis means periosteum, inflammation of the periosteum. Okay, so inflammation of periosteum and sclerosis is present here. In sclerosing osteomyelitis, focal and diffuse, here sclerosis takes place in the bone marrow, which is also called which is endo inside, है ना. So it is called as endosteal sclerosis. But in Gary's osteomyelitis, periosteal sclerosis is present, so it is called as supracortical or subperiosteal. Supracortical, above the cortical, or subperiosteal means below the periosteum. So it will raise the periosteum because it is below it. Okay, so periosteum is present here, focal and diffuse it is here in endosteum. Cortical plates are here. Gary's are here in periosteum, below the periosteum and above the cortical bone plate. Below periosteum, above periosteum and above cortical. In periosteum, supracortical and subperiosteal. Okay, so and thickening of periosteum. This is the periosteum and it will get thickens because here the sclerosis spread, and here reversal means here lines, prominent reversal and resting lines are present here, so it will give onion peel skin appearance. Okay, now clinical features seen in children and in young adults. Gary's osteomyelitis are seen in children and young adults almost exclusively in mandible. It is almost exclusively seen in mandible, not in maxilla. Okay, mild infection. It is a mild infection. Good host response is present here. Then radiographic features are feature I already told you. Onion skin appearance or duplication of duplication of cortical plates. Okay, also seen in osteosarcoma and Ewing sarcoma. Okay, prominent reversal and resting lines also seen in Paget's disease and all type of sclerosing osteomyelitis. Here our osteomyelitis is completed now. Thank you.